Fred will cue me. I figured, but I don't want to look over at him. Welcome to VNA Health Highlights, a program of the Visiting Nurse Association of Cape Cod. I'm Jeanne Sarnosky, and on today's program we're going to learn a little bit more about osteoporosis and spinal fractures. We are lucky today to have as our guests Dr. Gordon Nakata and a patient of his, Susan Clowry. Is that correct? Good. Thank you both so much for being here. I appreciate your time.
Thank you.
It was a great story as we do a little preview of the questions ahead of time, and as I was reading some of them of specifically your story, Suzanne. We'll get to that, but it just seems like quite a success story.
Lots of fun.
So just for viewers' sake, I was like to know who we're talking to a little bit. So Dr. Nakata, I'll start with you of how did you come to Cape Cod and what's a little bit of your history? And
it's a long story, actually. I'm from California originally.
Oh,
but,
okay.
My wife is from Providence, and I trained at Brown. So Cape Cod is a place I'd been to and visited, and I actually know Dr. Houle, who's one of my partners.
Okay.
And so I was more or less recruited by Dr. Houle. And I've been here for about 5 years now.
Oh, yeah.
Almost 6.
So you must like it. You're still here.
I love it. Big open spaces. I love the ocean. Being from California, I feel very at home.
You just flipped from one coast to the other.
It's easy.
Yeah. Well, it's probably a little colder this year.
A little bit. Last year was a little bit of a teaser. I thought I was home for a while.
Yeah, we fooled you. So we'll get right into it because I know we have a lot to cover,
Sure.
but let's talk about osteoporosis just from the viewer's point of learning. How would you best define osteoporosis? I know people have heard the word.
Yeah, osteoporosis actually can come from multiple different disease entities. Most commonly, it's a problem with calcium absorption. So what can happen is if the body does not absorb calcium in combination with vitamin D, your bone density is diminished. And when it's in that state, it's fragile, it's weakened, and it takes very little to fracture. So osteoporosis is a very broad term for people with diminished bone density.
Is it a big problem?
It's a very major problem. Last estimate I heard, there's close to 200 million cases worldwide.
Wow.
And a lot of it's undiagnosed.
Wow. Is your patient load heavy with osteoporosis?
It is. Here on Cape Cod, we have one of the oldest populations in the U.S., is my understanding, and so we have a very high occurrence of osteoporosis.
So the nature of the disease lends itself to an older population?
Mostly.
It is mostly.
Not exclusively. Yeah. You can also have it in the setting of people who have early menopause or people who don't absorb calcium because of digestive problems. And you can also have people who have hormonal problems, especially the parathyroid.
Is it men and women? Because I think probably viewers think of women mostly.
It is mostly women. It's about 1.5, 1.6 to 1 in favor of women.
Really?
So you're the lucky ones.
Why is that? Is it just because of the hormonal chain differences?
It is, actually. It's related to menopause, and we think the lack of estrogen after menopause. So younger women can actually get it if they go through menopause early or if they have those other factors I discussed.
Right. Now, are there warning signs of a...
That's the problem, is it's mostly a silent disease, and so you may not know you're walking around with it until you fracture.
Ooh.
And there's more education out there now, so people are thinking to ask their doctors, can I get surveyed for this? But it's not done routinely. As
part of, say, if people are really good at having an annual physical done, primary might not step up right away and say,
correct.
Yeah, you've hit a certain age, or not necessarily.
Right. Unfortunately, as a specialist, I find that I'm sometimes, or more often than I'd like to, having the first conversation about osteoporosis.
Really?
Yeah.
Are people surprised when you tell them?
They are.
Because there's no symptom that they're aware of.
Right. So if you tell someone that they have a broken spinal bone, it's often a shock, actually. They thought it was just a strain.
I would definitely think so. Even when I was reviewing the questions, I thought, you mean someone could have a spinal fracture and not know it?
Right.
That was it. Okay, so if they come into your office, with a spinal fracture unknowingly. Are there other risks involved with walking? I mean, how do you determine how long they've been walking around with it? And
it's sometimes hard to tell. So the usual story is some relatively minor incident that kicks it off. I was bending over, sometimes I sneezed, I rolled over in bed wrong. So it doesn't have to be a major car accident or a fall out of a building that causes it. In fact, the tip-off is often that they have extreme pain after something that's very minor and benign. But that pain tends to be very severe and doesn't go away. You know, because most people write it off as being elderly, deconditioned. I sprained my back while I was gardening. And often that is the case, but it has to be somewhere in the back of your mind as a physician that it could be something else.
Yeah. So people themselves, in self-diagnosing, will poo-poo it because of age-related or...
Especially that generation.
Yeah.
Because they're used to getting through pain with Tylenol and rest.
Yeah.
And they're not going to the doctor for every sprain.
So how do they get to you? What inspires them to get to that next step? Do they come from the primary or...?
Often from the primary, often from the emergency room.
Oh.
And more it's from word of mouth from people in the community. Someone had a neighbor or a friend that had something similar. And so it's gaining more momentum there, which is good. The patients are being their own advocates.
Yes, yeah. So talk about what were some of the other risks of spinal fracture, other than it just sounds like
So
awful.
aside from the metabolic condition and people who are not absorbing calcium, there's the risk from cancer. Lung cancer, breast cancer, prostate cancer, something called multiple myeloma. They can all go to the bone, and that can also weaken the bone, and then they fracture.
Oh, so not just the osteoporosis. You mean
Correct.
It could be because of some of these other diseases that you'd wind up with the same
Yes, so
fracture.
people who have a history of cancer, we need to be very vigilant about those people if they have acute onset of severe pain that's not getting better.
Okay, so that gives you a different age population then too, probably.
Correct,
is that right?
It does.
Gender as well?
Gender as well.
So it's just really, as we started this and we kind of focused on osteoporosis, that's the female target.
Yes.
But for some of these other spinal fracture issues that come because of the cancers, can be anybody.
Right, so if you have, for example, a younger man who has a fracture discovered on MRI, then that really raises a red flag as to what caused that bone to be compromised, because it's probably not osteoporosis or primary osteoporosis. So when men do have it, it's even more of a red flag for something else being amiss, as opposed to primary osteoporosis, which is mostly women.
Okay. So is it spinal fracture? That's because that's what you see, or disease process-wise, it could be any fracture, could be leg, could be ankle, or does it tend to go to the spine?
The spine is actually the most common. It's twice as common as hip fractures.
Okay.
So in osteoporosis, it affects the entire body. You can fracture the wrist, the hips, long bones, spine. But spinal fractures are twice as common as hip fractures, which most people are aware of and know about.
Yeah.
But just having the old back pain from working in the garden is often, as you said, it's dismissed.
Right. Okay. So let's talk next about kyphosis. That was sort of the next. Is this the treatment for the spinal fracture? That's the next step?
So kyphosis is really the culmination of one or multiple fractures that leads to a very pronounced curvature of the spine.
Okay.
So you see some people who are walking very hunched over, or they have what they call the dowager's hump.
Yeah.
And it's not because of bad posture, it's not because they're lazy, it's because their bones are collapsing and causing them to bend forward. So that angulation, that kyphosis, is what predisposes these people to pneumonia, because the rib cage cannot expand if they're bent over like this. The belly's sticking out because the organs have no place to go, and the spine is doing this.
Makes sense. Yep.
And pneumonia is one of the main complicating factors from kyphosis, which comes from the osteoporotic fractures.
Got it. So kyphosis is sort of the compilation of disease.
It is. It can happen from one fracture, but more typically it's from multiple undiagnosed fractures over a long period of time.
And there wouldn't be other symptoms. I mean, other than, like you said, it's the pain and people tend to buck up and
right.
That's my life.
That's it.
Wow.
Yeah.
it must be quite a challenge when they walk in then and you make these discoveries.
It's harder because the degree to which you can correct that is limited. What we're really trying to do is correct some of it and prevent worsening of it. So if you can catch these fractures early, you hope to prevent that progress.
Okay. Is it automatic that one would go to another?
It is not automatic, but it's more
likely?
frequent than not.
Yeah, yeah. And why wouldn't we quick go fix it while we can?
That's one school of thought.
Before it becomes, is that right? Yeah.
You know, there are some patients who don't have much pain and get better just with time, rest, and narcotics. And we are tempted to leave those people alone and not intervene. And it's reasonable as long as they're not collapsing. But at those people, we do get x-rays serially to make sure that they're not starting to head that way.
So you can watch the progression or lack thereof.
Or intervene before it gets too far.
Oh, yeah. So what do you do?
Well, traditionally or currently we have a treatment for that where you actually stabilize the fracture using bone cement. And we can go into that further now
sure.
or later if you like.
That'd be great. Yeah.
The idea is that the central part of the bone is the weakest and will tend to collapse and create a wedge, and multiple wedges lead to the curve, the kyphosis.
Okay.
So what we do is we insert needles or cannulas into the broken bone or bones. You can do more than one. And then we insert balloons into that broken bone.
Sure, yeah, great.
So if this is one single segment of bone out of your entire spinal column.
So people can visualize a lot of those stacked on top of each other.
Correct, so this would be one of several if you could see through me.
Okay.
So under x-ray guidance, what we can do is take a needle and through that needle insert this cannula here. And you won't be able to see it, but what I can do is then inflate that balloon to make a pocket.
Okay.
And in the process of doing that, you can actually take a wedge fracture and restore a lot of the height.
Right.
But more importantly, what you're doing is you're making a cavity here so that when you take this out, you can then put cement in here in a controlled fashion.
Okay.
And that is what solidifies the fracture and prevents further collapse. And if you glue the pieces back together, you also help with pain control.
Okay. Does that limit flexibility, that cementing? Does that change the flexibility for the patient? Or
it does not.
It's an individual.
Right, it's one bone. So between two bones is a squishy disc or shock absorber, and that's where the motion occurs. So you don't stiffen or affect the adjacent areas.
So we're not cementing anything together to its neighbor, any of that?
No, you are not.
Yep, okay. Now, in Suzanne's case, was it started with this treatment, or?
No, I'm sure she's going to want to tell you more about it herself, but it was a bit of a process to get there. And, you know, actually that's the best way to start is with pain control, because if some people can get better with Tylenol or a little bit of pain medication and rest, once again, if they're not collapsing, they can heal it on their own, because ultimately all of these fractures will heal. But how far does it go in terms of quality of life and pain and deformity before you decide to intervene?
Right. And will they heal at that angle, and this is where we are now forever, right?
Yeah, you got what you got at that point. But if someone's not having much pain, then it's good to start with narcotics and perhaps bed rest. In the past, what we would do is tell people to go lie in bed for 2 to 4 weeks.
Is that what it is? That was my question, how long? Yeah.
And it works. I mean, people heal the fractures, but the problem is if you make someone lie flat in bed for that period of time, there's about a 20% mortality rate, death rate.
Oh, wow.
Because the pneumonia builds up, skin breakdown occurs, blood clots develop.
Yep.
Not to mention the narcotic use, the constipation, depression, and it just ends up being a big spiral.
Yeah. Yeah, so the whole quality of life is a challenge to take on if one follows that first treatment.
Correct.
Yeah.
If the pain itself isn't bad, then the treatment in that form is bad.
Right, right. So what you just demonstrated, was that the balloon kyphoplasty?
Correct.
All right. So are there benefits other than that discussion of lying in bed for 4 weeks has its own challenges? What are some of the other benefits of doing the balloon kyphoplasty?
So about 8 out of 10 times in my experience, it significantly helps with the pain, especially when they load bear. When someone's lying flat, it's usually a reasonable amount of pain. When they stand up and gravity pulls on them, they hurt. So if you can solidify it, about 80% of people feel better after the procedure. Second is that you prevent further collapse of the bone, so they don't develop the kyphosis.
Okay.
And in the worst case scenario, if it gets really bad, the bone can actually push back into the spinal cord and cause weakness, paralysis, or spinal cord injury. In that event, it's a very major surgery to correct a very severe problem in someone who's in their 70s, 80s, or 90s,
Yep.
and it's very dangerous.
So is there height loss in some of the deterioration?
Correct. So
Does this help restore some of that, or?
I think it does, but mostly because of pain control. So when people are feeling better, they stand straighter.
Oh, yeah.
But we're really
Good
not going to
point.
expand your spinal column by inches
So,
doing this.
so the wedge piece would not necessarily add height, but it straightens you up, so you have the
It does, and it
comfort
does help.
in the
It does
image
help in
of-
that regard.
Yeah, yeah. If we talked about what's one of the most important things you would like viewers to know about this procedure?
Well, when you talk about any surgery, it's really risk and benefit. So if the benefit's about 80%, I'd say that's conservative for 80% success rate for pain control. But the risk is less than 1%.
Yeah.
Because we're using two X-ray machines, one from the top, one from the side. And as you're putting these needles in, it's done under live X-ray. And so the risk of putting cement in the wrong spot is very, very low.
Right.
And we've treated over 1,000 of these fractures
Really?
so far at our hospital and have not paralyzed or killed anyone, which is good news. But
Good to know.
that's the
That's
biggest
good.
concern when people are undergoing
Definitely.
spine surgery. And
Spine surgery is a scary term in and of
Sure.
itself. Yeah.
Yeah.
I'm sure viewers have that feeling as they watch us.
Right. So I think the benefit to risk ratio is pretty good for this procedure of all.
Okay. And what's the best way for someone to make that determination would be, gee, they're sitting at home watching the show now thinking, will they be nervous about that pain in my back that is reoccurring, or I know my posture has changed, maybe I should do something about it because I've heard that it is pretty safe.
Right. So the big message would be that it is potentially treatable, and strains and sprains happen, but they don't tend to persist and become so severe that you can't even get out of bed
Right.
for days and days and days. And there's a treatment out there which is much more efficient than what a lot of people live with. So some people do get through having fractures, and they get by and they go on to develop kyphosis, but it's hard to say how much pain they had, how many pain medications did they go through, how many social outings did they miss,
Right.
Healing it in that fashion.
So we try to discourage self-diagnosis.
It's a tough problem, isn't it?
Yeah. And then but to feel free to make the call and ask the questions, because that's the best way to find out.
Right. So like my patients with me, they put me to all the tough questions, and that's a good thing, because that means they're more involved, and there's a lot of right questions out there, and you won't know unless you ask.
Right. Good.
Yeah.
Well, I'm going to switch to Suzanne, because that was quite a story, and it was started with what we've already touched on, is people walking around with a spinal fracture not even realizing that that's what the problem is. So when were you first diagnosed with osteoporosis?
About 6 months after my first hip surgery, which was in October of '06. I went for a bone scan in April of the following year in '07 and was then diagnosed with osteoporosis.
Okay. What, did you have a hip fracture? You had a hip replacement, you said?
I had a hip fracture.
Okay.
Yes, I was knocked over by a 150-pound American bulldog
Oh,
in
okay.
a gravel driveway.
So you were one of those that had a real incident.
Yes,
For something to
I
show
did
up.
not cause the fracture myself, unfortunately.
Yeah, it wasn't, right.
But
slip and fall.
spent time in Cape Cod Hospital and rehab,
Okay.
and have done very well.
And that's when they first discovered the osteoporosis.
That's when I first discovered it, because my surgeon, my orthopedist, suggested, he thought that I might possibly have osteoporosis,
Okay.
and to get a bone scan as soon as possible.
Yeah, that was good. And then what happened after that? What was your next step?
Well, I
after
was diagnosed with osteoporosis, and rather than being put on a medication to correct it or to, ease it,
Right.
I was told that probably multiple vitamins would work better and not give me a reaction.
Yeah, some of those are pretty powerful drugs.
They can be.
Yeah.
Yes, they can be. So I went with that
Yeah.
for a while, and well, actually up until I could say last November.
Oh, wow.
Yes.
So fairly
and
recent.
it was Dr. Nakata, thank you, who said to me, you have, you know, experienced 2 hip fractures and several compression fractures.
Wow.
Why are you not taking something? You can take it. So
Yeah.
my primary care person prescribed Actonel, and I've been on that for 5 months, and I've been doing very well.
Oh, yeah. Because all the drugs are
and
so
it
different.
doesn't bother me at all.
Yep, everybody reacts differently. Yeah.
Yeah.
So you came in with a few spinal fractures?
I did. I came in with
Unwittingly?
a total of 6.
Wow.
The first 2, I was telling Dr. Nakata, the first one came, I was dealing with a casement window where you had the screens and the panes of glass.
Yep.
And I was taking care of an elderly woman, and she asked me to bring down the screen. And as I did to lift up the pane of glass, I could hear something snap.
You did?
Yes. And I was in severe pain and treated with a pain medication.
Pain med, yeah.
And it seemed to work, and it eased, and for a long period of time I was fine. So I never thought about it. And the second time it happened, I can't even tell you when, the same thing happened.
You heard it?
I did not hear the second
Oh, okay.
one. Yeah. But the third one was very significant. I have a darling cat, and I was cleaning the cat's box,
yeah.
and I lifted it, and
Wow.
I could feel something go.
Yeah. Does it
And-
tend to go that way, Dr. Nakata? If there's one, there's another, or not necessarily?
Well, it does increase geometrically. So if you have 1 fracture, the risk of the next one is 5-fold
Okay.
increase.
All
And
right.
if you have 2, it goes up to 12 times.
All right.
And so it's not one causing the other. It's more of a sign of how thin the bones are.
Okay. All right.
The reason why they escalate in frequency.
Yeah. So at this point, when you've had these multiple fractures, had you already seen Dr. Nakata or not yet?
No, I had not.
Okay. So when you arrived here, all of a sudden there's 6
right.
on the...
And I went with the last set of fractures. I did not know there were 2. To my doctor, and was given a medication to ease
Okay.
the pain, and told to get some rest. But I could not stand the pain. The pain was very severe. And so I went back, and I saw a nurse practitioner, and she sent me down the hall for x-rays, and lo and behold, there were 2 compression fractures. And she informed me that there was a process known as balloon kyphoplasty,
Yeah.
and who would I like to see? And I said I would like to see Dr. Nakata, because my neighbor had been very successfully
How do you
taken
like
care
word of mouth, huh?
And
That's
it
great.
is. It's wonderful. I live in
It
a senior
is.
community.
Everybody does that.
and
why wouldn't
everybody
you?
shares.
It's a
Yeah.
learning experience.
Yes.
I'm glad
It
that's
is.
happening.
Yeah, that is good. Because
So
people
from
wanna
there
hear
on
it.
in,
Someone who knows.
I was in his hands, and I'm fine today.
Yes, you are. That's great. So what have you noticed? What's different? So you had this procedure,
Yes, I did.
and for how many
For
fractures
2.
along? For 2?
I had 2.
Okay.
I believe it was L1 and L4.
Did they happen at the same time, or do you go in and do one, and 2 weeks later you
No,
go do the other
Dr.
one?
Nakata did both at the
Both
same
at the
time.
same time.
Yes.
Yep.
And I love it because it's an outpatient procedure.
Oh, it is.
Went in at like 9 o'clock in the morning, and by 12:15 I was on my way home.
Wow. So what do you notice?
I noticed more agility
Okay.
and no pain.
No pain.
I have pain from the other fractures because those were not repairable,
Right.
but it's an Advil, pardon me,
No,
works
that's fine.
wonders.
Yeah.
It
yeah.
does.
So you're able to get around. I think in part of the bio information I had, you were surgery one day and
Yes.
on your way to on a trip somewhere
Well,
shortly after.
my niece was to be married the next week, and
Oh, yeah.
I went down, drove the 250 miles, and had a wonderful time. And
Did
drove
you
back.
hop out every 50
No,
miles
I
and walk
didn't
around
have
the car?
to.
And, no.
No,
Wow.
I didn't have to. And before the surgery, I had to use a pillow behind me
Oh yeah, when you're sitting on,
Just
in the
sitting
car,
up in the
or
car.
the chair, yeah.
And even when I was sitting in a chair for
Yeah.
any length of time, and I don't use a pillow. It's great.
So what would you say to viewers who are nervous about surgeries or new procedures?
I would say don't worry about it.
Yeah.
You know, yes, there's going to be a certain amount of worry. I was worried too. You know, when you mention the word back surgery, you think of all the horror stories that you could possibly think of.
Yeah.
But having been through enough surgery myself, I can easily say that if you know at the end it's going to be a relief and it's going to help you, then it would behoove you to accept it and to go for the surgery.
Right.
Because it's certainly, in my case, it was just amazing.
Yeah. And no harm in at least asking
No.
the questions.
No. And I've talked to a lot of people about it too myself. And they've listened,
Yeah.
but I don't know whether they've
You got to
done
circle
anything.
back and
Yes,
find out
yeah.
if they really.
Right.
You'll know. You can't tell, but you'll know. Are there things that you can do now that you couldn't do before?
Not really.
Okay.
I feel very comfortable being able to do
You're free again.
free things. The
Yeah.
only thing I don't do is I don't run around the block.
Oh, yeah.
But that's an age factor
You
thing
know.
too.
That's
So-
a big club that you're in there.
Yes,
Yeah.
yes.
Yeah. Well,
I can
we only
bow
have
out on
about
that.
2 minutes left, believe it or not. So I wonder, are there any critical items that we haven't touched on that you wish viewers would know? And I know there's some other doctors you're in practice with and other procedures that you perform that.
Right, so
may
there's four of us actually, and we're all board certified neurosurgeons.
Okay.
And so sort of what we take pride in here on Cape Cod is tailoring the approach and being different from Boston in one, our accessibility, and number two, the fact that we do mostly minimally invasive work. So we've done
yeah.
the big reconstructive surgeries, but we can also tailor it to a population that's 80 plus years old.
Right.
Kyphoplasty being a perfect example, but it also speaks to the minimally invasive decompressions and fusions that we do, as well as taking out brain tumors. And we have the newest in equipment. We're very proud of sort of a younger staff now at Cape Cod Hospital,
Yeah.
and a new facility that's really up to date.
Yeah.
And so we're just hoping that people gain confidence in Cape Cod Hospital. It seems like there's been some reticence, and back surgery has never had a stellar reputation.
Right.
But we think we have a lot to offer, especially with things such as kyphoplasty.
Yes.
that are
I think,
minimally
yeah,
invasive.
traditionally just the whole thought of back surgery is just a scary topic in itself. So
Naturally.
this should build some security for people to know that we have state-of-the-art facilities and physicians available to us right here without having to travel off Cape.
But also patients like Suzanne who ask the right questions, who go in open-eyed and have a good outlook. You know, if it's fixable, I'm going to get better, I'm going to do this, and that's probably part of why she's done so well.
Such a success story.
Right.
Great. Well, thank you so much
Thank
for
you.
being here
You're
today. I
welcome.
appreciate your time. It was very educational. Loved it. All right.
Thank you.
All right. And I'm Jeanne Sarnosky, wishing you good health and good health care. Let me just sit for a minute.